All okay? Yeah.
Yep, David, we're now quorate.
Thank you very much. Okay, good afternoon, everybody, and warm welcome to the September meeting of the Integrated Care Board. Great to see everybody. Just remind everybody that the Integrated Care Board meetings are meetings in public. They're not public meetings. And I just ask if everybody could keep their cameras off as we get into the agenda, with the exception of the chair and those presenting, and then we'll bring people in for questions as we go forward. And if you could make sure your microphones are all on mute, that would be really helpful. We'll have an opportunity for questions that have been submitted prior to the board to be addressed shortly as we get into the business, and there'll be a further opportunity at the end of the meeting for anybody to ask any questions on the agenda that they wish to raise. So we'll just move into apologies, Jill, if we can, for the meeting today. I've got Alex Brett, Chief People Officer, noted, and I think Mish Irvine is joining us for the meeting. Heather Johnston and Lynn Tolley is attending for Heather, and John Rouse. And I also think Tracy Bullock may have given apologies as well today. And Claire, are you here to represent that University Hospital? Yeah.
I wouldn't say fill Tracy's shoes, but here for your H&M. Yeah.
Okay, and just while we're doing apologies, if I can just do a welcome. I don't know if Pat Flaherty has joined us on the call. Pat was due to join us today. Pat, are you on the call?
He hasn't yet, David.
He hasn't come. So when Pat joins, I just wanted to welcome him because this would be his first meeting as Chief Executive of Staffordshire County Council, joining us today. So if we could just go to the Leadership Compact before we get into the meeting. You'll see the Leadership Compact within the papers at enclosure 1. And the compact is a very important document that's used in all of our meetings across the ICB and ICS and guides the way that we conduct our business. And we'll return to that at the end of the meeting just to check that we believe we have done just so. I'm advised that we are quorate, and I'll just ask if there are any conflicts of interest in relation to any items on the agenda other than those which we have appended as the conflicts of interest register. So just check nobody has any conflicts. Great. So we'll move, if we can, into the minutes of the meeting that was held on the 20th of July. And if we can just go through those for accuracy first. Page 1, page 2, page 3, page 4, page 5, page 6, 7, 8, 9, 10, 11, 12 and 13. Is everybody happy with the content and accuracy of those minutes? Thank you, and thank you to Jill for those. In terms of the action tracker, we have an update on the first action there. Lynn, I think you're going to update us on the Oliver McGowan.
Thank you, David.
If we could just take that verbal update now, that would be good.
Absolutely, thank you. So the ICB has appointed a project manager for the Oliver McGowan training, and that person will be in the system for the next 3 years. She'll be trained to cascade the training by Train the Trainer across regulated providers, and will provide that, as I said, over the next 3 years while they're in post. The arrangement will support, but won't be sufficient at this time because there's 70,000 staff that we've got to do that training to. So that's why we're using the Train the Trainer model. The education at the moment is not in this category. However, Paula McGowan, Oliver's mum, is lobbying government at this time and insisting that the training should be mandatory within the education as well.
Okay, thank you, Lynn. So, Lynn, in terms of this action with the post that you've described, we can turn the screen and bring it back for updates as part of the general reporting, yeah?
Yes, I think we can, yes.
Okay, that's great. Phil, just on the other red item there, we have the update. Anything else that you want to alert the board to today?
Not particularly, thanks, Chair. Just to say, it's obviously very much a live thing, given that we're in a period of industrial action now. We're continuing with our cycle of planning for, responding to, and reviewing stroke learning from periods of industrial action, so that our response can improve each time we're faced with the challenges, and all of that is being logged from a workforce perspective, from an activity perspective, performance perspective, patient impact perspective, and then I also understand from a financial perspective as well in terms of the costs associated, but it's very much a live and ongoing thing at the moment. Thanks.
Thanks very much, Phil, for that. So with that, we'll move off the action tracker. I think everything else is covered on there. And Tracy, we've had a number of questions submitted by members of the public in advance of the meeting, and I'd be grateful if you would just take us through the questions that we've received.
Thank you, Chair. I mean, one of the questions received is for Lisa for the AGM, so I'll just go through the ones I'm aware of the ICB.
Yeah, please.
So this is a question from David Jones, and I am in correspondence with David just to say on his letters that he's been sending in, and also I'm going to their PPG groups in November. So what he's asking today, though, is when changes are made to service provision, how is their impact assessed relative to your mandated and statutory obligations? For example, one of your statutory obligations is to tackle inequalities in outcomes, experience and access. If any proposed changes result in significant reduction in access by a particular community, then what level of change would be allowed and how will that community be involved and or notified?
Okay, so Chris, are you taking that?
Yes, Chair, and apologies for the voice. I've got COVID at the moment, so I'll try and get through as best I can. So thank you for the question. I think Tracy's got some points around kind of the general duty to consult and how we engage with communities more generally. Specifically around service change, it can of course take many different forms. Generally speaking, we'd expect it to be around kind of a change to the range of services that are available or the geographical location from which those services are delivered, and the process follows quite a structured methodology. So that would include, for example, the outlining the case for change, clinical oversight of those proposals, and of course an assessment on the impact on patients and communities who are using those services. Depending on the scale of the proposed change, we may have to work alongside local government scrutiny colleagues for what's called substantial service changes. We may also work with NHS England, and we may have to conduct formal consultation. I think within all our service change proposals, though, we'd expect some co-production, or at least those changes to be informed by the patients who use those services or have got lived experience of those services. As the question suggests, we do have particular statutory obligations, so the Equality Act 2010, for example, or in relation to health inequalities, and we discharge those through mechanisms such as the quality impact assessment or equality impact assessment. And where there are issues identified through those reviews, we are required to give regard to how we can mitigate those impacts, and that's all included then in the final kind of proposals that come through our committee and board structures, as well of course the individual provider organisation's own corporate governance processes, recognising that the services generally tend to be provided by organisations within our system rather than the ICB per se.
Chris, thanks for the full answer there, and please let us know if you're struggling as you go through the meeting. Tracy?
Yes, thank you, Chair. And we do have our broader engagement and involvement, which we do with the public. And in relation to the question that's been asked, there's several levels, and I think Chris has just articulated the formal level, which is our statutory obligations to involve our public in a significant service change. And when that happens, that there's various ways of which we do that. And we use all sorts of mechanisms, realising we don't always reach the communities that we want to. So our People and Communities Assembly, as part of our strategy, are tasked with finding out how we best reach our communities. We have many communities across Staffordshire and Stoke-on-Trent that are extremely diverse, and the people on our People and Communities Assembly help us reach those communities. So there's several ways in which we do it depending on what the issue was. I realise that some people would like us to come out to all the different groups, and of course we're open to do that wherever we can. So I'll leave it there, Chair, and like I say, I'm in dialogue with David as well.
Okay, thank you, Tracy. So with that said, can we move into the other questions that we've got for today's meeting in advance?
Okay, the next ones are from Ian Sy, and there's 3 questions, and I'll take them and then pause after each one. So in terms of mental health, the ICB has previously reported that female mental health patients needing mental health inpatient services have had to be placed out of area due to demand and capacity issues locally. Is this still the case? And if so, how many ICB area female mental health patients are at present placed out of area?
Thanks, Tracy, and thank you, Ian, for the question. Chris, are you picking that one up as well?
I am indeed, Chair. Thank you. So just in terms of context, it is perhaps important to note that across Staffordshire and Stoke-on-Trent, we do have very low numbers of inappropriate out of area placements and are in the upper quartile of performance in England. But there are occasions when we do have patients accessing inpatient services out of area. Currently, we have 2 in direct response to the question in both those cases, and it is generally the case for other patients that we've placed in out of area placements. They are female patients who we've had to place in neighbouring systems because of a lack of capacity of psychiatric intensive care units or PICU in our own system. That it's not an issue that's unique to Staffordshire and Stoke-on-Trent, and through the West Midlands Mental Health and Learning Disability and Autism Provider Collaborative, there was a review conducted earlier this year that identified a gap in relation to female PICU beds right across the West Midlands area. ICBs are required to produce a draft plan by March 2024 to localise and realign mental health and learning disability autism inpatient services over a 3-year period, and we'll work with the provider collaborative to take their findings into those local plans. Thank you.
Thanks, Chris. And the second question from Ian.
So this is around from the Finance and Performance Report. Disparity in virtual ward utilisation between North and South. Could this be clarified, please? What are the dimensions of this disparity, and what has been as yet identified as the main drivers of this disparity?
Bill?
Yeah, okay, thank you. Yeah, so virtual wards are central to the National UEC Urgent Emergency Care Recovery Plan. They're also central to our own plan locally, and will be an increasing part of our plans for tackling demand over winter this year. So the simple answer in terms of that disparity, which is absolutely right, that's been highlighted, is that the model that we have in the north is more mature than the one in the south due to the timings essentially of when it's been put in place. So the north model was developed throughout last winter, led by UH&M as its main provider, and this has gained momentum as time's gone on, both in terms of capacity, in terms of workforce, and also in terms of clinical buy-in, if you like, to the pathways that we have. So in the north, we've got 3 pathways developed: acute frailty, COPD, and also remote monitoring for high-intensity users. The south, conversely, the virtual ward beds are governed by RWT in the southwest, and UHDB, so Derby Burton, in the southeast. So at the moment in the south, we've only got the acute frailty pathway working. So we're working at the moment to ramp up utilisation and capacity in the north still, because we recognise we're still not quite where we want to be, and also to grow that capacity very rapidly in the next few months as we head towards winter. And just to provide the very latest figures on it, as at the end of August, total utilisation for our 199 virtual ward beds, 57%. In the north, 83% of those are utilised, and in the south it's around 30%. So we do have a whole work stream, as I say, as part of the winter plan and our urgent care board in terms of improving that. But the highlighting of the disparity is absolutely correct at this point in time.
Thanks very much, Phil, for that full response. And the final question from Ian Tracy.
There's no additional funding provided for GP winter surge. I appreciate that such is external funded. It is, however, astonishing that a key area of care delivery has been exempt from additional winter surge funding. Could a flavour as how the portfolio will be resolving within current allocation winter surges within primary care?
Thank you, Tracy. Chris, is this you or Paddy?
I think I'm going to start, Chair, and then Paddy's going to come in to offer some further thoughts, if that's okay.
Absolutely.
So there is a proposal that's been developed by the primary care team, supported through urgent care board, which will invite general practice to provide more capacity through the winter period. That's very similar to last year, and indeed winter's gone by, but from an ICB perspective for us last year, where general practice colleagues work incredibly hard to deliver more appointments generally from kind of mid-December through to mid-April. There is elsewhere on the agenda papers that kind of outline the challenging financial environment that we're in, and it's right and proper in those circumstances. I think that the service is asked to do all it can to identify some flexibilities. We have done that from within existing allocations, and we are able to repurpose some of that to support this activity. But we do also need to continue to have discussions with system colleagues on identifying further funds to support the full range of proposals. So I'm going to stop there, and then Paddy, I think you're going to talk about a little bit about kind of current activity levels.
Thanks, Chris. Welcome. Hi, Paddy.
Thank you. Ian, I always like to start a conversation about GP appointments by just describing some of the numbers. We often hear in the press that you can't get a GP appointment. In the last 12 months up to date, there have been over 6 million appointments in general practice in Staffordshire and Stoke-on-Trent ICS, which is a colossal number, I think you'll agree. But winter happens in general practice as well as other parts of the system, and we recognise that we need to provide additional capacity. Partly because the workforce model is changing. We are moving from a GP partner model into a workforce model which is perhaps more fixed, and we're losing some of the flexibility that the partnership model has given us to date. So we are seeing increasing numbers of GP salaried doctors and increasing additional roles. The additional roles, a whole range of different people who are now working in general practice, and they are now seeing probably about 16% of face-to-face contacts. As that's happened, the flexibility to absorb surge has diminished, and so we last winter, and as Chris has outlined, we would seek to commission more activity. Last year we bought about.
I think Paddy may have frozen on Teams.
Back now.
Yeah, here now, Paddy,
yes.
Loud and clear.
Yeah. So last year we bought about 7% increase in same day activity, and about half of that 6 million appointments are booked same day. So that was a sort of sizable increase in activity, and that was delivered in a hub and spoke model. So we had some respiratory hubs, notably by some of our federations, including the North Staffordshire GP Federation, but also spokes, extra capacity at practice level, and we will seek to run the same model this year. It was well received by general practice to help out, and was fully utilised, and we will see that happening again this year. Thank you.
Thank you very much, Paddy. Tracy?
That is the end of the questions, Chair, but just to note that we are in a pre-election period for Staffordshire, and that we may have to take some questions at the end and respond after that, depending on the questions.
Yeah, thanks for raising that, Tracy. That's exactly what we'll do. But if I could just thank David Jones and Ian Syme for their questions today. Thank you, both of you. We'll move on. I said at the start, I just wanted to formally welcome Pat Flaherty to the meeting. Pat's Chief Executive of Staffordshire County Council. Pat, I know you're on the call now, so a warm welcome and look forward to working with you going forward as a key member of the board. So if we could take the Chair and Chief Executive update, I'll hand over to Peter in a moment, but there's just a couple of issues I wanted to pick out at the start, if I could. The first one was to congratulate Support Staffordshire for the achievement of the Voluntary Centre Quality Accreditation mark, and you'll see from the report that's quite a prestigious award that Support Staffordshire have received, so congratulations to everybody involved in that. It's very important to just touch on the verdict in the trial of the Lucy Letby case, which I'm sure has shocked everybody across the country and across our catchment area. And in response to the verdict, NHSE has stated that they are committed to doing everything possible to prevent anything like this happening again. As you can understand, as an integrated care system and integrated care board, we are taking these matters incredibly seriously and building on the structures and processes that we've already established to make sure that we're reviewing them in light of the initial verdict, but also further guidance that will come in due course. So I just wanted to pick up a few of those just to cite the board on today. The first one being the Patient Safety Incident Response Framework, which is being reviewed and implemented, and Josie Spencer and Heather Johnston are leading that through the quality and safety work. The Fit and Proper Persons Framework is going to be quite a major undertaking, which we're keen to get underway. It will start this month and will involve all members of the board in terms of how we beef up the annual assessment of fit and proper persons of everybody sat around the boardroom table, and we'll make sure that those initiatives are implemented robustly. And I've met with the chairs of the system, the NHS chairs of the system, to actually discuss how we're going to operate that comprehensively across the patch. And the next one was around freedom to speak up, and important that we strengthen those roles. We have an executive lead, Tracy Shewan, and we have a non-executive director, Showkat Lal, who are our key leads with a network of freedom to speak up champions working across the organisation. And again, that will be reviewed and strengthened where necessary as we move forward. The final thing on this I just wanted to bring to the board's attention is an important document that's been released since this report was pulled together, and that's the Sexual Safety and Healthcare Organisational Charter, which has been released by NHS England, and those who work, train and learn within healthcare systems have a right to be safe and feel supported at work. And the Charter identifies 10 initiatives that organisations should sign up to, benchmark, and if not yet able to demonstrate achievement in those areas, ensure that they do so as quickly as possible. And I've asked the People Committee through Showkat to actually look at this in detail. But with your support today, what I'm keen to do is to sign up to this on the NHS England website to make sure that we are in agreement with the contents of the Charter, and also we are committed to make sure that we will do all we can to make our services and as a workplace safe for everybody who accesses them. So I wanted to just make sure we'd covered that off today so that we can sign up to that through NHS England's website. Just moving on quickly, I want to just pick up the Nursing Times Award at 6-1. Great that we've been nominated for the upskilling pilot in terms of the Nursing Times Awards, and good luck with that. And also just to acknowledge that from this week's Health and HSJ Patient Safety Awards, we've had some people who've have actually been winners as well in that. So the Primary Care Initiative of the year, the winner was Midlands Partnership University FT for the Psychological Therapy Service. And we also have, just looking for the other winners in this category, the University Hospital of North Midlands Care Excellent Framework, and lastly the Urgent Care Safety Initiative of the Year category. Local finalists included the University Hospital of Derby and Burton FT. So congratulations. It's important to acknowledge those awards and to celebrate where things have gone really well in terms of those projects. So Peter, I'll just hand over to you if you want to pick up the headlines, particularly around the performance and finance, and then we'll move into the main agenda.
Yeah, thanks, David. I really wanted to just talk in a roundy way about the position that we're facing at the moment. So from a financial point of view, we've had a couple of pretty good years, and unfortunately that positive performance is coming to an end. Context being nationally, that is true across the board, but we are facing some significant pressures, financial pressures at the moment, and that's of course unfortunately coupled with the reality of elective backlogs, which is again a truth across the entire country, but we are challenged locally in that regard. And urgent and emergency care, although the start of the year was relatively positive, we seem to again be in pressure in that regard. So we are facing challenges on a number of fronts, and of course winter isn't far around the corner, and COVID of course is still with us. I think there's a bit of a sometimes a lack of recognition of the reality that COVID is still present, albeit of course we are embarking on a substantial vaccination programme over coming weeks and months to manage and mitigate that over the winter. So we've got a number of pressures that exist in the system at the moment, and what that how that manifests itself sometimes of course is stress and pressure on individuals. And so it's important really in those kind of moments to reflect on just what a fantastic job the workforce across the NHS and social care of course is doing right now under, as I described it a moment ago, really significant pressure. The bit of course that I missed out, and I've just realised I missed out in that list a moment ago, is industrial action, which is ongoing, and of course we're unsure as to when that might end. So really significant pressure as we go into autumn and then of course into winter, which is traditionally seen as a particularly pressured time for the NHS and social care. So that's the negative news. That the positive news is that, you know, I feel confident that we will manage those pressures going forward, particularly that winter period, in the best way that we have ever done. And why am I saying that? Well, I think the building blocks that we've put in place over the last year or so in a number of regards will help us to achieve that. So I wrote 3 things down before coming on camera that I thought are worth noting. So firstly, how our urgent and emergency care teams across the system are now working together, breaking down barriers, focusing fundamentally on that patient journey, which is there is still work to be done in that regard, but I'm really heartened by how teams, people have come together on that UEC piece to work in a much better way than historically we have. The recovery programme, so I did mention the money challenges a moment ago, and therefore you won't be surprised that we are or have already embarked on a recovery programme to address that. And I'm delighted with the effort and energy of all parts of the system that have stepped into that space to say, right, what more can we do? How can we work differently? And then linked to that, I just want to mention the provider collaborative arrangements that have, over the last couple of years, led through Tracy Bullock, who chairs the Collaborative Development Board, have built the building blocks, the foundations for that collaborative piece to now move into the next phase of work. And some of that is orientated around taking on the continuing healthcare agenda, and I'm delighted that the Provider Collaborative Group have agreed to do that, and I'm absolutely convinced that they will do a wonderful job of overseeing the management, the leadership of that CHC agenda going forward. So I hope I've just painted a bit of a picture there of that. Yes, we have substantial challenges, absolutely, but I think the work that we've done over the last year or so puts us in as good a place as any system across the country to cope with what's to come.
Peter, thank you. Thank you for that. Just pause in case there are any points anybody wants to raise on any part of the agenda there. Julie?
Thanks very much, both. For me, I think it's important, because we are meeting in public here, is that the reports that we receive at our board here are a summary of what's been scrutinised at our assurance committees below, and I think it's really important for the public to understand the amount of scrutiny that comes before we actually produce these reports. However, just leading on from what you've just said there, Peter, is absolutely crucial to what you're saying are our people. And so in terms of your report, yours and David's report, I think it would be really useful to have the key people data that support that performance, because it's really, we've got in there the key performance indicators, but I think understanding where we are in terms of recruitment and retention and stress points, it would be really important to have that in there as well.
Thanks for the question, Julie. Peter?
Yeah, that's a really good point, isn't it? So absolutely, we'll make sure that the various measures that, as you rightly described, the people committee, the board committee that oversees that people agenda do scrutinise. But I'm sure we can get that in as a clear narrative in terms of progress. So thanks, Julie.
Okay. With that, any further points anybody wants to raise? Okay, so we're asked to note the updates in the report, and we'll move into item 8 if we can. And Paul, can I ask you to take us through the system recovery plan?
Yes, thank you, Chair. You've allocated me 20 minutes for this. 20 minutes for this item, which is great. So I thought what I'd do, Chair, is just quickly update you on where we are with the recovery plan, and then, as Peter was just saying there, perhaps just have a bit of a delve into the work that's being undertaken within the Provider Collaborative, and just ask Neil to say a few words on that, because I think it's a really, as Peter said, a really exciting development, and it's also going to work, because as we go through the recovery plan, I think where we've got to is that in order to fix things, we need to fix the whole patient pathway. The financial position is set out in the paper that follows actually on performance, so I'll just quickly give the headlines from that, because at month 4, which is the last month we're reporting on, we had a deficit at that point of 48 million. That's 34 million variance. Again, as Peter has said, unfortunately most parts of the country are seeing variance from plan. We're not alone. Into month 5, that variance has continued to the extent that this week I have sat down with the regional finance director and said that I don't think we can get to break even. We are required to report break even. That's what we're doing. But I've explained to her, and at Finance and Performance Committee, we were very open about that. So it is going to be probably impossible now to catch up on where we are. But the recovery plan is therefore absolutely essential in order to ensure that we keep as close to the target as we can in the current financial year, but probably more importantly that we right size our services so that we move into 24-25 in a sustainable financial position, because the problems that we're seeing are recurrent. So just to give us sort of a sense of the extent of the challenges that we face, we spend as a system a little over 3 billion, but we've seen 50 million of what we call excess inflation. So that's inflation over and above the allocations. So it's an astonishing amount. And you know, we already went into the year with an extremely high risk plan, and we're very clear with the board here and with regulators that our plan was high risk, and we were determined to get to balance, financial balance, if we could. Were it not for that extent of excess inflation, we would have had a chance of getting there. The other big driver, which is the basis for the recovery plan, as you've seen in the papers, is that we've seen a further explosion in the cost of continuing healthcare, CHC. And the work that we've done as a system is really to examine the pathways of patients who end up receiving CHC. And there's a lot of evidence that we've collected now which shows that actually we're not making the lives of those people better as a result of, in some cases, spending quite a lot of money on their care. So we've really focused this recovery plan on making it better for our people, our 1.2 million people who live in Staffordshire and Stoke. That is the focus of the recovery plan. The financial benefits, if we deliver those benefits to the patient pathway, the financial benefits will follow, and we've got the evidence that shows that. So we do know through the analysis, and again I think we've probably referred to this in previous board meetings, we do know that we spend an awful lot more on CHC per head of population than just about all other systems in the country. So that in this sense is kind of good news, because it means it's a clear area for us to focus in on. It's something that we can sort out if we work as a system on the whole pathway. And we looked at the event that's referred to on the 14th of July when we came together. We looked at a patient journey, obviously anonymous, but the patient was a gentleman who his care journey started from independent living at home. He had a fall, he was admitted, he was then discharged to assess. He stayed there for quite a long time. In the end, he went on to care home care on a one-to-one package, which is where there are basically people standing at the end of the bed around the clock. And then eventually he died. And with the benefit of looking back at the pathway, that gentleman's life did not need to entail that degree of intervention. It was extremely unlikely that it extended his life, that the intervention it certainly affected his mobility and his independence, and it certainly cost a huge amount of money. So it's an example where we know, working together across that whole pathway, that we can make our patients' lives better into the future, and as I say, save money on the back of it. So I think Peter's said, and I completely agree with him that that we should feel really positive about this recovery plan. It's obviously an extremely difficult financial situation, but we have responded to that in a way which I think will make things significantly better for our population, as well as enabling us to get back on track financially. In the pack, we've set out the details of what we've called the 7 big areas. The session on the 14th of July that I referred to agreed that we really need to focus down. We'd agreed to focus down on one thing, which is the CHC, but associated with that, a large proportion of patients who require CHC are people in the age bracket above 75. And Lorna Clarkson, who's in Paul Emerson's team, has done a lot of work around the over 75-year-old cohort, and we can see quite clearly that there's more that we can do for that cohort and provide better care for that cohort. So we've linked that care into the solution across the 7 areas we're addressing, where patients don't need to be admitted in the first place. When they do, we're looking to ensure better discharge. We've discovered that a large number of patients who end up requiring CHC and hospital care come from the care home sector. So we've got Richard Harling from the Staffordshire County Council leading that stream of work, which is looking at can we provide better care for people in care homes. We're looking at end-of-life care, which again, we know that 65% of our population die in hospital. Very few of that 65% want to die in hospital. So honouring patients' wishes will be better, but also less expensive. Focusing on frail and focusing on people who fall. That makes it the 7 areas that we're developing into the plan. Beneath those 7 headlines, we have, it's about 30, it's 32 at the moment, specific projects. Against each of those, we've got a lead, a named lead. That named lead has a very clear metric, which is relevant to that particular area. And collectively, those metrics come together to mean that fewer patients will require hospital inpatient stay. That is quantified, and then we know from the evidence that when patients are cared for in the community at home, and that they're less likely to require CHC. Some still will, but not as many, and that's what drives the financial benefit. So in terms of where we are, we're now just about ready to launch the. In the second, ask Neil to say a few words about the provider collaborative, which is now meeting. The recovery plan is going to a meeting, or 2 meetings next week. One is the system performance group, which is a meeting of the executives. So basically all of us who report to chief executives in the system, we come together monthly. We have the responsibility to oversee performance, to decide what to escalate and what needs sorting out. That's on Wednesday, so the recovery plan is going there for consideration. And then we arranged a further system event, so a follow on to the 14th of July event. That's on Friday next week, Friday the 29th. And that will be a system meeting where we come together to get behind the recovery plan and to agree how we're going to ensure that collectively we deliver those benefits that we know are achievable. And then finally, the approval to the plan is going to be sought at the Finance and Performance Committee, which meets the following week on Tuesday the 3rd, that Megan Nurse chairs. A system meeting, so all system partners come together to present the recovery plan to that committee for approval. And from that point on, and in fact, effectively we were already up and running because we've already had the first meeting of the project leads, which are the people running the projects beneath the 7, so the 32 that I mentioned. Those individuals have come together on a weekly basis. That started last week and is continuing tomorrow. So we're on track. We said that we would produce a recovery plan to this point. I think when we went away from the 14th of July, some of us were looking forward to some holidays and wondering whether we could actually do what we said, which was to launch the thing on the 1st of September. Well, we did. We got there. The projects were all set up, and we have, in this sense, used the summer really, really well. And again, as Peter said, I think it's been a real, massive achievement for the system to come together. In the past, this would have been seen as a problem of one part of the system to sort out. We now recognise that we can't fix these things alone. We fix them together, and that way we make the lives of our patients better as well as saving money. That's where we are, Chair. And if I could, perhaps, if that's through you, invite Neil Carr just to say a few words, because the CHC Provider Collaborative is the vehicle by which we will deliver many of these improvements.
Thanks very much, Paul. Neil, over to you.
Thank you, Chair. Thank you, Paul. I can build on what Paul is saying. The collaborative working is nothing short of exceptional. What we did in the name of continuing healthcare, we asked chief executives to put their most senior people onto these sorts of issues. So we were working in real partnership. So, for example, at UH&M, we have the chief operating officer leading the work from their perspective, but playing into the continuing care group. And similarly, in the other organisations, we now have ownership, and the support from local authorities has been, again, nothing short of exceptional. So I really believe we are now working as a whole system very effectively. The continuing healthcare group, as Paul said, Chair, is dependent on being very clear what's happening, alternatives to admission, what's happening with accelerated discharge from hospital, etc. So the group that Tracy leads, that collaborative, is absolutely pivotal to making sure left hand and right hand is connected. But because of the significant work involved in continuing healthcare, there will be a bridge from that group of Tracy's into the continuing healthcare group that I will feed directly into the chief executive community, because we will need pace and action behind that. But I think the take-home message is, without exception, all organisations have put their most senior people forward. Dr. Harling, for example, from Staffordshire County Council. There is a group now working to develop a very detailed action plan based on what the other groups are doing. And I believe we'll have a coordinated approach to share with chief executives in the next 2 to 3 weeks. And we will certainly see real traction happening from now. But where we will achieve a critical mass, without a shadow of a doubt, is from the end of October onwards, owned by the system.
Neil, thanks very much for that. And Paul, thank you as well for the report. We'll bring some questions in at the moment. And we've said consistently, the point Neil's just made and you made earlier about the teamwork in the one system approach. You know, these are really difficult challenges that we face on the road ahead. They will be made, you know, more achievable, or our ability to achieve our plans is much strengthened by the way that the system is wrapping around this and seeing it as a system issue rather than, as you described, just one organisation's problem. Just one question I had, Paul, on the 7 big ticket items. I just wondered where prescribing fitted into your discussions, because obviously previously we've talked about those costs being quite high and probably some efficiencies there without any impact on the service that people receive.
Yeah, thank you, David. Yes, so prescribing medicines optimization is a strand. So we have appointed Mark Seaton. Well, Paul Edmondson-Jones has appointed Mark Seaton into his group as lead pharmacist. Mark has now established a group of the pharmacists from across the system and includes partners in Derbyshire as well in that group. So the kind of the two parts answer to your question. The first part is that medicines continues to be looked at within the different parts of the system. It forms part of the ICB primary care use of medicines, and it forms part of the use of medicines within the trust. And the group that I referred to that Mark is setting up effectively sits above that, pulls together things and looks at where working collectively we can get even more benefit. And there are quite a few examples of that where actually by harmonising the use of drugs across secondary and primary care, we can actually get further benefits than we could individually. So Mark has that task now of finding those additional opportunities, as I say, working with his colleagues that previously were not available to us because we did work in those individual organisations.
Thanks very much, Paul, for that. Just pause there and offer the opportunity for any board members to ask questions on the recovery plan. Jack?
Thank you, Chair. Thank you, Paul, for the update. I just wanted to sort of make a comment really around the medication prescribing in terms of primary care, and I guess sort of say a little bit around that. I think along with the agenda around prevention and population health management and the prevention agenda, a lot of the management of long-term conditions sit within general practice and primary care. And along with that, I think I recognise the cost of drugs is gone up, and the cost of prescribing has gone up. And seemingly, it would look like that most of that expenditure occurs. But I think that's partly the investment that we need for the future. And that's about preventing unwanted hospital admission, preventing things like strokes, heart attacks. So I think there's some of that, I guess, sort of upfront pain. I think, and I just wanted to make that point really, is we're investing in not only the future of the workforce, but also more importantly, the future of individuals that live within our health economy in terms of preventing those illness and disease that will have an impact not only on hospital and the NHS, but also on that sort of that care around disability, around sort of social care for the future as well.
Thanks, Jack. Julie.
Thanks very much, Chair. I just wanted to thank Paul and Neil actually for really bringing to life this particular report. I think it was really well explained, and just how what an excellent opportunity is to showcase the collaborative working around this particular initiative. I think the other thing is that what I've learned from outside of this meeting as well is how it's bringing forward the things that are in our portfolios at pace, which again, it makes that really important that we've got the portfolios correct. I suppose my only one question, just for members of the public, that there is a lot of work here going on to improve the lives of individuals with a saving that comes at the end of it. What it doesn't mean is if people are eligible with the criteria, it isn't about taking away their right to CHC if the eligibility criteria is met.
Absolutely, and well made point, Julie. Thank you for that. Megan.
Thank you. Thanks, David, and thank you, Paul and Neil. I suppose I just wanted to reiterate really the amount of work which has taken place since the middle of July around developing the recovery plan and getting us to this point. And it has very much been a piece of work which has been driven across the system, which is fantastic. Because if it isn't driven across the system, it's not going to deliver for us, is it? And then just in terms of the big ticket 7, which you outlined, Paul, that in a way, the ones which I'm most pleased to see are actually the 5, 6, and 7, falls prevention, severe frailty, and end of life, because these are issues which I think we can really drive forwards now, perhaps in a way we haven't previously. And these are completely about making life better for the citizens and patients that live within the Staffordshire Stoke-on-Trent. So I'm delighted that they're there, and I think this is a something which can improve lives and also deliver some financial savings at the same time. Thank you.
Thanks very much, Megan. Peter.
Yeah, thank you, and thanks, Paul, for describing the situation very well. Well, from CEO to CEO, firstly, I want to say thank you, Neil, for grasping the challenge, and B, coming on and describing, as you just have done, the opportunity that we've got. A really big thank you. I just want to mention 2 things. Firstly, I mean, for me, this is much an OD, an organisational development description. We're embarking on something that, as I say, is all about why integrated care systems were created in the first place. And that, that hasn't just suddenly appeared overnight. That's been a product of, as I mentioned earlier, the provider collaboratives and our collective efforts over the last year or 2 to get relationships, interactions, how we do things together into a different place. So that's a really important point, because those foundations create opportunity for many other things equivalent to this going forward. So there's a really bigger thing here, isn't there, at play? But the other thing I wanted to touch on, and Julie's comment sort of sparked my thoughts on this. This is very much about ensuring that the recovery word perhaps brings connotations of money, brings connotations of financial challenge, and we've been very careful and made sure as we go through this to not focus our attention, our efforts on that subject. For me, this is absolutely about ensuring that how we support our population is done in a more proactive and preventative way. And in achieving that, in theory, of course, you spend less money on the reactive side of healthcare, and people become better off as a result of it in their lives, because they don't deteriorate as quickly from a health and wellbeing point of view. So if we can achieve this, it's an absolute win-win. And as I've been through my career, I've seen all of the best quality initiatives have financial benefit and vice versa. I've seen very little that simply achieved a financial benefit alone or a quality benefit alone. Generally, the 2 are achieved together. So I absolutely echo Julie's comments about this being focused fundamentally on a proactive and, as I say, a preventative health agenda.
Thanks, Peter. Point well made. Neil?
Thanks very much indeed, David. I just want to reiterate what I think Peter's covered, and that is, Julie, if anyone's entitled to service, they will receive that service. But we know there's a lot of people who don't need to receive that level of service, and that money could legitimately be saved. And I think we need to recognise that. Megan, in regards to ELF, end of life, long-term conditions and frailty, we've done a tremendous amount of work, and people like Professor Zafar Iqbal, working with Dr. Lorna Clarkson, has done a deep dive, really. So we've got the science now, we've got the data, we know what's making a difference. We're being far more creative, for example, in talking to the fire service in terms of what roles they might have around trips, slips, falls, etc. So there is a lot of work happening that I've got no doubt will prevent admissions into hospital. And I think it's just worth reiterating, this is to improve the patient care and the people that are there. GPs have been instrumental. If we're going to make real progress here, GPs need to play a key role. And the support we've had from people like Lorna Clarkson, Rachel Gallagher et al. Has been nothing short of exceptional. Thank you.
Thanks very much, Neil, for that. Just check any further points that anybody wants to make. Okay, Paul, Neil, everybody involved in this. This has, been an exceptional piece of work. We've got clear recommendations for today that we'll take now. So we're being asked to be assured and note the progress of the system recovery plan. I think we've had a full update today on that. Note that the final plan will be submitted for approval to the October Finance and Performance Committee meeting, and then to the ICB board for ratification. And I think it's also just worth noting the point begun by Julie Holder and reinforced by both Neil and Peter about the quality issues for people who have an entitlement to particularly continuing healthcare going forward. So if everybody's happy to receive that report, and we'll bring it back in October, we'll move on into item 9, and I'm going to ask Lynn Tolley if Lynn will take us through the quality and safety report. And on conclusion of that, Lynn, I'll invite Josie as chair of the Quality and Safety Committee just to give the exception report that Josie's got in the pack of papers as well. Over to you, Lynn, and welcome.
Thank you, David. Welcome, everyone. Just to start off, we've discussed before about the Quality and Safety Committee going to bi-monthly, and we've started that. We've actually started we've had our first deep dive in August. That covered harm reviewers, and when we went into harm reviews, we talked about the waiting list validation, we talked about the targets, work producing the DNAs, and using IT intelligence into helping some of those DNAs, and also about communication, that two-way communication in regards to patients knowing where to go if they do deteriorate whilst they're waiting. We also looked at maternity services within that deep dive, and actually we also looked at how the new 3-year delivery plan is actually how the action plans, lots of action plans within maternity, and how they're linking into now those 4 themes within the 3-year delivery plan. Moving on to MPFT, we all know there's been a CQC visit into the PICU and the adult psychiatric intensive care units, and they were rated inadequate at that particular time. There was a follow-up visit in June, and actually that wasn't a rated inspection when the CQC came back. They did find there was further improvements to be made, but just to provide some additional assurance, we are doing joint visits with the provider and CQC to just check out those action plans and progress against the action plans. And progress is being made. There's lots of positive work going on there as well. And I just wanted to celebrate within there that celebrate, and it's not just MPFT, it's UH&M as well, as a provider who are absolutely recognising the healthcare support workers within their organisations and the work they're doing. You can see that MPFT have done work with recognising and having educational conferences. You can see that UH&M are doing initiatives which is being recognised by NHS England in regards to individuals who perhaps haven't got the qualifications that they quite need to get into care, and actually enabling them to come into care and just reinforce some of that workforce. Moving on to UH&M and maternity services. What we've done from maternity services, following the CQC report, we've developed and set up, we've had our first one, which is a System Maternity Oversight and Assurance Group, and it's established in line with the regional direction. And it's going to be co-chaired by the CNTO of the ICB and the Regional Chief Nurse of NHS England, and that will provide additional oversight. There's a lot of action plans that are already in place and being worked on by the Trust prior to CQC coming in, but obviously those action plans are being revisited now and strengthened. On the 7th of September, we carried out a visit to UH&M's maternity service ourselves, NHS England, and we talked to staff, and I want to link this to David's comment earlier about that freedom to speak up. So we not only did a visit, spoke to staff about how they were feeling, how they thought they were progressing against the action plans, but also spoke to them about actually, did they feel they could speak up? Had they got a strong management structure and they felt able to speak up? And we spoke to non-qualified, qualified staff, consultants alike, and they all felt able to speak up. I'd also like to recognise, just on that visit as well, is that the staff that we spoke to were so motivated, considering maternity as such a negative press at the moment nationally. The maternity services in UH&M, they absolutely acknowledge their leadership team, which is reflected in the CQC report, but it was just their want to actually get things right, and we really need to harness that to make sure that just keeps going in regards to motivation of the staff. Just moving on then, just Ivetsi Bank, it's an independent hospital. For those of you who don't know Ivetsi Bank, it provides 37 beds to children and young people aged between 12 and 18 years. It is actually overseen by the provider collaborative, Birmingham Women's and Children's NHS Trust. We work very closely with them, and we've undertaken at least one visit, and we're undertaking another one in 2 weeks' time, just to go in and just see for ourselves exactly what's going on there. But we do work very, very closely with the provider collaborative in that area. And I'll just cover the 2 policies, although Josie will pick them up. There's 2 policies that did come to our Quality and Safety Committee for approval, and Josie will be asking for them to be ratified at this board. I'm happy to take any questions or hand over to Josie.
Thanks very much, Lynn. Let's take Josie's report and then we'll open it up for any questions against the report. But thank you very much for that, Lynn. Josie.
Thank you, David, and thank you, Lynn. Lynn has covered pretty much everything within the report. There is those 2 policies, safeguarding children and young people policy and the safeguarding training policy, that apologies in my report I'd put recommended for the board to approve. That should have said ratification, so my apologies for that. There's just Lynn's already touched on the positive feedback from the staff at UH&M maternity, which was discussed in the report. And the only other thing that I want, well, 2 things actually I wanted to mention. We moved, if you remember, into a new approach to quality impact assessments back in March, April. We had the first report through to the committee on that new process, and it was very positive feedback. Things are working well, and I think we've got a much more slick process now to get things actually properly looked at an earlier point than we probably had before, and that links back to one of the questions, David, from a member of the public earlier on. And then I do want to just mention something about the continuous quality improvement work. Lots of things going on in this space, always a very positive report when it comes to committee. And one of the things I hadn't noted in the report but I wanted to say today is that we've now got over 300 staff across the system trained in continuous quality improvement methodology. And given all the pressures on services we've got at the moment and have had for some time, I think that's a significant achievement for the system and shows a commitment to wanting to continually improve our services for the people that we serve. So I just wanted to make the board aware of that. Thank you, David.
Josie, thanks very much for very full report there, both written and verbal. Just a couple of points I just wanted to pick up. And Lynn, going back to the maternity oversight and assurance group, really pleased that you raised the point about freedom to speak up there. And I guess on an ongoing basis, will all staff, you know, from sort of junior staff through to consultant staff, will they get their voice heard through that mechanism?
They've got their own mechanism within the providers, but when we carry out visits to all our providers now, we're asking staff, do they feel enabled to actually speak up? So yes, we speak to the staff and we'll do it that way.
Right, okay, thanks. And I just wanted to acknowledge the piece for University Hospital around the improvement in vacancy numbers being reduced, and particularly around registered nurses and midwives. That sounded a really innovative piece of work and actually bucking the trend. Is that correct?
Yeah, they are. I mean, their overall maternity, they're closing the gap. I can't tell you what the numbers are because they are low numbers now in regards to maternity, but actually all our providers now are looking at innovative ways to actually increase their workforce, especially the non-registered workforce.
Yeah, and that's what you touched on.
Yeah.
So thanks very much for that, Len. I'll bring Julie in.
Thanks very much, David. I think the two reports together as well show, as I referred to earlier, just how much work's done in committee and the assurance that Josie's given us. My question was around maternity, and you alluded to it, Lynn, is the negative press I really have concern about all our people who work in the areas of maternity, is the impact of that continuous negative press. My question was, there isn't a single regulatory framework from a governance point of view that maternity have to report against, and it's crept, to my mind, over the course of the last few years following Ockenden. It's not to say it's wrong, but it's obviously right, but it actually causes an awful lot of extra work to report against those. And I just wondered whether the CQC ratings were impacted by the whole process of reporting and the governance, or are CQC looking just at the element, and I think this might be true, I'm not sure, around the element of safety, or is it because of that growth in the reporting arrangements? Hope that makes sense.
Thank you, Julie. I'll try and answer that question. The CQC are still reporting against their regulatory areas of quality. I don't think they've caught up. If you look at all of what reports are going through, whether you look at Saving Babies' Lives, the Ockenden report, and now you've got the 3-year delivery plan. If you go back many, many years, when we looked at mid-staffs, the failings of mid-staffs, one of those was about multiple action plans and no ownership. Actually, what we're working with UHM at the moment is using the 3-year delivery plan, which has 4 clear themes, and actually linking all the action plans into there. So we have one overarching one, and actually trying to pull that together, Julie, because there's going to be action plans that have threads that are themed. So we need to keep all of those action plans really tight.
Thank you.
Yep, thanks, Julie. Thanks, Lynn. Megan?
Thank you. Thanks, Lynn. I just wanted to highlight the section on under 4.2 and the conference which took place in July around learning from the lives and deaths of people with a learning disability and autistic people. So I think it's fantastic that the conference took place, and it looks like you had a really wide range of membership at that conference. And I noticed there were several positive themes that came out of that, but in particular I wanted to ask a question around the areas where further work's needed, and your report picks out DNA, CPR, lack of advocacy support, and next of kin not always being recorded correctly. I suppose I want to know whether you're confident that we're doing things that we need to do to make fast improvements in those areas, because it's so important that we get this right as a system, isn't it?
Thank you, and thank you very much for picking up the when we did the event, because it was well received and the feedback was really, really positive. Regarding these particular areas, we have really good engagement with system partners in regards to these areas, but DNA CPR has been there for a long, long time, and it just keeps going round in circles, doesn't it, in regards to we think we're getting it right and we're going off. But I have to say there's that much focus on leader at the moment. Money's coming in and people are really engaged, and I mean widely engaged in regards to those groups. So I think we will start seeing improvement, but there's always pockets, isn't there, where you see that we need some improvement. But we have got engagement all the way across our organisation, and we've got the health passport, that that initiative that has been rolled out. And we were talking about it the other day of, you know, we've got IT and that sort of thing. We need to start bringing us up to date with everything. The health passport has been and we've got engagement events and videos and all sorts of things. So hopefully it will improve, Megan, but actually saying hopefully is what we need is demonstrative improvement. And that's what we need to actually be able to demonstrate. So thank you.
Thanks for the question, Megan. Lynn, thank you for that. Just pause and check. Has anybody else got any point they want to raise with Lynn or Josie on anything that we've heard? Okay, thank you. The board is being asked to do a number of things, just run through those formally, receive the reports and seek clarification and further action as appropriate. Everybody has had the opportunity, hopefully, to do that. Secondly, to be assured in relation to the key quality assurances and patient safety activity undertaken in respect of matters relevant to all parts of the integrated care system. And then importantly, to ratify the decisions of the Quality and Safety Committee with regards to the Safeguarding Children and Young People's Policy and the Safeguarding Training Policy. The board content with those recommendations. Thank you, colleagues. We'll move into item 10 then, if we can, which is the Finance and Performance Report. And Paul Brown, Phil Smith will lead off on this, and then I'll ask Megan Nurse, our non-executive lead in this area, to present her assurance escalation report. So, Paul, are you going to lead out and Phil join in?
I mean, if I may, just in terms of the finances, I think I've covered the headlines I wanted to cover anyway, Chair, in the first item. So I'll just hand straight over to Phil to talk through the other performance areas.
Thanks, Paul.
Okay, thanks, Paul. Thanks, Chair. Okay, what I'll do is draw out some particular areas of the report, and then obviously happy to answer questions on other bits as required. I think it's probably fair to say, in terms of the continued periods of industrial action, that remains a challenge to all aspects of delivery across the system. Certainly across planned and urgent care, we see it having significant impact, both in terms of the planning for the period, the actual response to an activity that has to be stood down or delivered in a different way, and then recovery from. So that's the backdrop that our performance sits against. I'll start just with elective and backlogs. So we remain in tier 1, which is national escalation in this area, particularly focused around the UH&M position. I'll talk through a couple of the end of August numbers, but I think the important message for me is that we have been on a really strong improvement path from the UH&M point of view. I've seen the evidence that demonstrates the fact that the industrial action is actually really severely limiting the progress that's been able to be made there. So, for example, during August, we were predicting that all of the 78-week waiters would be seen by the end of September, but the industrial action over that period has meant that we've ended August with 177. Also looking to the wider population, because obviously only just under 2/3 of our population flows through to UH&M. We've seen an increase in the level of patients waiting 78 weeks at other providers, most notably University Hospitals, Derby, Burton. We were around 40 at the end of July, and that's increased to 89 at the end of August. So clearly that impact that we're feeling is being felt elsewhere. So as part of the Tier 1 support that we receive, I've notified the board previously that we've got national support embedded within UHNM to support in terms of how we're managing our activity, making sure we're getting the greatest productivity we can out of our theatres, and making sure we're managing and validating our lists in the right way. We've got a particular focus at the moment, in line with the national ask, to look at any patient who would breach 65-week wait by the end of March, and ensuring that they have had a first outpatient appointment by the end of October. So I think that's a really important milestone to work towards, because once patients have been seen in that outpatient setting, there is then a much clearer idea in terms of onward investigations required or onward care, or indeed it may be that their care needs can be met elsewhere without requiring acute intervention. So we're just working through at the moment how we can achieve that for our population. Most specialties, it's looking like that will be achievable. However, there are a number of tricky ones where we've got significant waits, such as spinal, orthopedics, the ones that have been challenging all throughout the year in terms of elective recovery. So we're working through that bit at the moment. From an urgent and emergency care perspective, we remain in Tier 2, which is regional escalation oversight. And I'm pleased to say, actually, we've got some good, strong overall progress with delivery of the urgent care improvement plan. We've had some significant achievements, notably the integrated discharge hub went live at the beginning of September. There's a great deal of work for that hub to do, but it brings partners together in a new way in terms of ensuring the timeliness and adequacy of patient flow out of hospital to avoid unnecessary delays there. We have seen a significant spike in acuity, an evidenced spike in acuity, in fact, during the early part of September, linked to the heat wave and the usual exacerbations you would expect around that. But I'm pleased to say that as the heat has dissipated, and indeed it's quite chilly today, those pressures have released. So the system has responded well in terms of escalating and then de-escalating. Similarly, as I've said, with industrial action, particularly yesterday, which saw the first period for us where both consultants and junior doctors were taking action, the system planned and responded really well there with no undue delays. I'll just touch briefly on winter and winter planning. Mentioned it earlier in terms of primary care virtual wards. We had a national winter event on Monday this week, which I was present at, and we also had a full day regional visit to our system last Tuesday, where we physically walked through the pathways, and then also talked through all of our plans. So we've had some good feedback from that. Our focus for winter is very much on building on the learning from last year, building on the approach that we've got that we know that works, and making sure we keep that collective view in terms of what our demand profile is, our capacity, using workforce in innovative ways. We've touched on that a bit already, and also ensuring that escalation is appropriate and timely in order to enable us to de-escalate. And as has been mentioned earlier in the session today, ensuring that everything we're doing can demonstrate value for money from a financial perspective, and also clearly, most importantly, from a patient perspective. All partners have a role in managing surge. Nobody is exempt from it, but I will say that this year, and I'll bring the plan through to ICB board in November, it's starting its governance journey in the next week or two. We've got a real focus on trying to engage the wider sector. So we've got some really exciting work that's been done with the hospice sector, which will give us much needed capacity over winter and ensure that patients are receiving that care, end-of-life patients are receiving care in the best possible setting. And we've also got other innovative solutions we're looking at in terms of using the voluntary sector to a much greater degree to support people with settling in once they've had a period of escalation, and continuing and growing our partnership with the fire and rescue service, who've already demonstrated the massive impact they can have in terms of supporting falls, and looking to expand that and look at other areas. So I'll bring further updates, and we'll be working through that in the next few weeks. As I say, it'll come through to this board in November for final ratification. Thank you. I'll pause there.
Phil, thanks very much. Very comprehensive summary of the report there. Grateful for that. Megan, can I bring you in now to give the exception report as Chair of Finance and Performance, and then we'll take any questions.
Thanks, David. You've got assurance reports from our August and September committee meetings. Those committee meetings have very full agendas, so there is quite a lot of detail within those assurance reports. Given that, the two things I wanted to pull out from the September report, and the first one is on page 84, please, and relates to the direct award of the contract for NHS community services in East Staffordshire. If the board remembers, back in January, it accepted the recommendation of the Finance Performance Committee to adopt a cooperative contract procurement approach with a current service provider. So work's been taking place since that decision back in January. And that approach really recognises the importance of service providers sharing an aligned vision as part of the ICS, and offers enhanced value in terms of economies of scale, workforce resilience, and integration with other community services across Staffordshire and Stoke-on-Trent. So FPC, after consideration in September meeting, are recommending that the board ratify the decision to approve the direct award for an 18-month term commencing on the 1st of October at 10.3 million per annum, which is a total contract value of 15.45 million. So that's the first thing I want to pull to your attention, please. And then the second one is on the next page, and just sets out the discussion we had and support the committee gave for a centralised repeat prescription management service, which is going to be piloted in Burton and Lichfield, and delivered in partnership with PCNs there. Thank you.
Good if I came off mute. Thanks very much, Megan. Just pause there for any comments from any member of the board. Okay, obviously covered off those issues. Megan, in terms of the escalation issues, I note we have been asked to take assurance from your reports. Is there any further recommendations that need to come out of the two items that you've raised?
No, I'm happy that we've picked up on a conversation around finance and performance elements separately from Phil and Paul. So there's nothing further I'd like to highlight. It isn't in the escalation reports.
Right. Okay, thank you very much, Megan. Okay, so the board has been asked to note the exceptions highlighted in the reports that you've received. I'm assuming everybody is content with that. Please let me know if you've got further comments. No. Okay, thank you. So we'll move into the committee assurance reports if we can. Item 11, Julie, I'd be grateful if you would take the audit committee exception report, please.
Yeah, thanks, David. I'll assume read. So just a couple of things to ask board to note. One is the change and agree in this particular case. The change in frequency of meetings of the committee to 4+1, which is quite a normal frequency for audit committees. And to note that this would involve an extraordinary meeting of the board to approve financial statements in June 2024. I'd also just draw attention to the outcome of external audits on the mental health investment standard, where this was really scrutinised by the committee and was considered by Finance and Performance also, and the discrepancy has since been rectified. And the value for money assessment, which we've talked about at length previously and today, that the rating given around that reflects the risk associated with achieving break even for 23-24, but we have talked about that. I'd also just like to commend and note the joined up approach around recommendations following financial sustainability audits, where the finance community have come together to look at those recommendations and improve and implement the audit recommendations that came forward. So really specifically in terms of approval of agreeing a change to the audit committee frequency to 4+1, and for the board to be involved in approving financial or all necessary statements in June 24.
Thank you very much for that, Julie. We won't repeat that recommendation. We'll propose that as the recommendation, as well as receipt of the escalations contained in the report. Board members happy to endorse Julie's recommendation as Chair of Audit. Thank you very much, Julie, for the report. Moving to item 12. Showkat, if we could take the exception report for people, culture and inclusion.
Thank you, Chair. Just a couple of things I really wanted to feedback on. One was the staff story. We had a really powerful staff story from Isuda, who's completed a level 2 healthcare support worker apprenticeship, and her passion was really evident to see in terms of the apprenticeship pathway, her own energy and interest in wanting to work in health and social care. And it was a fantastic example of some of the workforce planning issues that we've got and how we were trying to address them. So I really wanted to flag that up at the beginning of this. The other things I just wanted to highlight, it was one of the probably the most comprehensive meetings I've ever been to, in the sense that we had quite detailed discussions around the surge plan and the ICS recovery plan, and in particular highlighting the 7 big ticket programs around system recovery and the progress against system recovery. But what was really different in terms of the way people, culture and inclusion looked at these issues was the implications around workforce. And it's been great to see in other parts of the board meeting today, where many colleagues have spoken in the presentation of their report around workforce planning implications and workforce planning issues. But within the committee, there was a real a DNA, a thread going through about recognising what those implications are, what it means for the workforce, where those gaps are, and what we need to start, well, what we are already doing, but alongside that, what are the considerations we need to make. So it was a really comprehensive meeting with a lot of detail, but actually some very precision and detailed analysis of where the gaps are and further work and activity that was required. The rest, Chair, is set out in the paper itself. It's fairly self-explanatory, and happy to pick up any questions.
Showkat, thanks for the report there, and actually for just expressing that energy that I think has come through the board meeting today, particularly that one system, everything coming together, that golden thread through, very clear plans, rather than, as we heard, from Lynn earlier, about multiple plans, everything coming back to that one route. So really encouraging report there, and thank you very much for that. The escalations and the risk review are in the summary of Showkat's report. So just pause there. Any questions for Showkat on that report? No, thank you very much. Can I just check if there is any other business? I've had nothing identified or notified to me in advance of the meeting. Just pause and check. Okay, thank you very much. So we'll just pause there if we can to ask if we have any questions from the floor relating to any item on today's agenda. And if you could put your hand up and I will invite you to speak. Ian, welcome.
Thank you, Chairman. Thank you previously for the comprehensive response to my questions. Quickly, 2 comments, if I may, to start off with, and I've got a specific question about UDAs, units of dental activity. With regard to continuing healthcare, I think Chair, I got involved in continuing healthcare quite some years back. And obviously I get very twitchy when I see continuing healthcare, but I welcome being discussed. I welcome what Julie Holder said, in as much as the eligibility criteria. This isn't about eligibility criteria. If people are eligible, etc., they will get continuing healthcare. Although I have to tell you, as an advocate, sometimes it's really protracted and a bit of a minefield. The other thing is maternity. I think it's recognised that maternity services throughout the nation need to improve and improve quite dramatically. I think that's recognised within the NHS. I think that's recognised elsewhere. And situations like East Kent, Nottingham, Shrewsbury, Morecambe, etc., weren't, I realise the choice of words, but that wasn't bad press. They were actualities, and there were a lot of tragedies there. So, there is a need obviously to support the staff, but there's a need to dramatically improve maternity services in the country. Obviously, they are national initiatives, they workforce initiatives, etc., etc. Now to the units of dental activity. I noticed on the finance report, and it's now your duty, isn't it? You monitor dentistry. That finance and performance report, that you were 347,997, 347,997 behind plans for units of dental activity. I thought that's a bit big, so I checked with the ICB. I understand it's around 187,000 behind plan. But I noticed also that you're not going to get on plan this fiscal year to red. It's highly unlikely. I realise also that the contentious element here, how to access NHS dentists or having to go private, is the unit of dental activity and the payments for units of dental activity. And obviously there are negotiations with the dentistry associations and government. But are there any kind of plans going to be brought forward to somehow get on some degree of track for people being able to access NHS dentists, because it is a problem, not just in our area, it's a problem nationally.
Ian, thanks very much for putting those points and your questions so clearly. Chris, I take I'll hand over to you on specifically on the dentistry issue to update Ian if you're able, if your voice will hold out.
Thank you, Chair. So there's a couple of points I'll make if I may. So first is that Ian's absolutely right, and thank you, Ian. You alerted to us when the papers were published that in the executive summary of the performance report, there's a reference to the current UDA activity being in round numbers 348,000 units below plan. That is indeed an error, and I think we've communicated that through to you.
Yes,
Ian. So it is 182,000, which nonetheless is still a big number. That's against a plan of about 482,000, so it's a shortfall of about 38% in Q1. The vast majority of that is attributable to a really difficult April, and I'm pleased to say that it has improved every month since then. So the month 4, which is the last formally validated data set, is 82% delivery, and unvalidated data for month 5 suggests that we're going to get over to 90%. But nonetheless, your wider point is also recognised there are some difficulties for patients accessing NHS dentistry. We discussed that in meeting with the MPs earlier this week. And yesterday, myself and colleagues from the primary care team met with representatives from the local dental committee to start to formulate a short-term action plan for those actions that the ICB can take forward. You're absolutely right, again, that there is a context here in terms of the national contract for dentistry, and we operate within parameters, but nonetheless, through conversation with LDC colleagues, there are some areas that we can progress at local level, and we'll be bringing that through Finance and Performance Committee in the next couple of months, certainly before the end of this calendar year.
Brilliant, thank you.
Ian, thank you for your questions. Any further points anybody wants to raise? Okay, thank you. Tracy, I'll just check with you. Have we had any online questions that have come in that we need to address before we conclude?
There's no questions that have come online, come in while people have been watching the video, the meeting.
Okay, so just want to turn to the meeting effectiveness and just check that everybody has had full and ample opportunity to raise anything that they wish to raise, and had the ample opportunity to ask any questions on any of the risks or other content that's been discussed today. And also, just to pause, we said at the start how important the ICS Partnership Leadership Compact is. Just checking that we've adhered to the leadership compact of trust, respect, courage, kindness and compassion, openness and honesty looking forward, and leading by example and system first. I guess a reflection from me, we've heard a lot about system first today in many of the presentations that we've received. So just pause if anybody has any final reflections on that. If not, we'll draw the meeting to a close, and thank you everybody for attending, both those members of the general public and also everybody else and the board for their contributions. The date and time of our next meeting is the 19th of October at 1 o'clock. At the moment, it is going to be held in public, but Tracy Shewan, our company secretary, is reviewing where those meetings will just fall, given the election period that was referred to earlier. So thank you, everybody, for your contributions. See you next month. Bye-bye.
Thanks.
Chair.
Bye. Bye.
Thank you. Bye-bye.